Welcome to the SJMC Grand Rounds, where our experts come together and discuss challenging cases. Witness a synergy of intellect and medical expertise as we embark on our continuing medical education journey together. Before we start, I would like to remind you to subscribe to our channel and enable notifications so as not to miss our upcoming episodes. Now let's begin.
Hello everyone, and welcome to our first Grand Rounds for the new CPD cycle, and this is the SJMC Cardiology Grand Rounds 34. And with me are my eminent colleagues, Dr. Kanan in the middle. Hi Kanan.
Hello.
And Dr. Choi at the bottom there.
Hi.
Okay. Hi everyone. So today is something unique, and actually I can participate because the theme is where cardiology and hematology cross. And I think that's very appropriate because blood flows through the heart. The heart is required to pump blood, so we are really intertwined. So we've got some interesting cases for you guys on the cardiology with hematology themed presentations, which I hope will interest you. But before we begin, I will just show a bit of housekeeping slides. If you're on YouTube chat, live chat, you can ask your questions there later at the end of the presentation. There are 3 cases in all, by the way. But you can also join us at Slido. Go to slido.com and enter 1549901, or just simply scan this QR code to reach that section, or it will take you, if you're on a mobile, it will take you to the Slido app and you can ask your questions there. A reminder again, please, many of you watch but don't subscribe. I think only 10-20% of you actually are subscribers. But if you subscribe, you'll be able to stay informed of our upcoming live stream. So please do subscribe to our channel. Okay. So without further ado, I think we will begin and we will start the presentation. So over to you, Dr. Kanan.
Thank you, Alan. Thank you for the introduction. Hello, everyone. Let's get going in the interest of time. Okay, the first case is someone that we saw about 4 months ago. It's an 88-year-old Indian gentleman who has been on our follow-up in this hospital for about 20 years. Several issues: hypertension, ischemic heart disease. About 6 years ago, he needed multi-vessel coronary angioplasty, mainly because of age, so we didn't send him for bypass surgery. Presentation then was effort angina, and after the angioplasty, he has been free of angina. He was also diagnosed to have moderate aortic valve stenosis, which we thought did not require any form of intervention, and he has had no complaints during his regular activities. He was diabetic. Next slide, please. He presented to the ER with a 3-day history of marked breathlessness and chest tightness during his morning walk. And the symptoms would settle with the rest. He had no symptoms at rest. Next, please. These are his regular medications: something for his diabetes, medicine for his blood pressure, some blood thinners because he's on. He has got multiple stents, and he has got a statin. Next, please. So I'll ask Dr. Choi, just based on the history alone, what differentials should we consider?
Thanks, Dr. Kanan. So we have an elderly gentleman with underlying ischemic heart disease, although he's been quite stable since the PCI. Top of the list, of course, we have to evaluate and assess for any progression of his coronary artery disease. He also has a bit of a moderate aortic stenosis to begin with, so we have to evaluate of the aortic stenosis. Hypertension alone can also, bring in symptoms. It could be because it is uncontrolled hypertension. Not to forget things that we do not see upon presentation, but being an elderly, sometimes arrhythmia should also be considered as well. For example, atrial fibrillation, and check for the other general beings, for example, anemia, nutrition, or even perhaps a GI bleed as well. This will be top of my list for this man.
Great. Sorry, next page. So this and one more. Basically, this summarizes what Dr. Choi has already said. Okay, so let's move on. Next, Alan. Oh, no, one before. Sorry. Sorry, give the game away. Anyway, so this is in the sequence of how we saw him, right? So in the clinic, he looked very comfortable sitting in a wheelchair. His jugular venous pressure was not elevated. There was no edema. The blood pressure was pretty good. The heart rate was regular. Clinically, there was no clinical cardiomegaly. The murmur of aortic stenosis remained unchanged over the years. The lungs were clear to auscultation, and the abdomen was normal. So this clinical examination certainly makes heart failure very unlikely. So there's no heart failure. So next, please. Then we examined him further. And Dr. Choi, could you comment on this photograph taken of this patient? This is the patient photograph taken by Dr. Yo, our ER doctor.
Yeah. So it brings me back the good old medical school days, where I guess for me the first sign to learn was actually to check the conjunctiva. Look for signs of pallor. I think probably most will agree that there's a very obvious pallor scene. Is pale, and for me, I always check with my own palms. That was how I was taught. Put your palm next to the patient. I think it's clinically very pale. Is that the thing?
Exactly. And this is an Indian man. You can see that his skin is not the usual dark, coloration. Next, please, Aaron. So other relevant negative clinical signs were there was no lymphadenopathy, there was no bone tenderness, no hepatosplenomegaly. So all this went searching for when you saw that he was very pale. Next. So what would be our working diagnosis now, Dr. Choi, after that, now that we have examined the patient?
So sounds like he has a significant anemia in him. So technically, the workup will be finding the cause of anemia. It could be a production problem, or it could be a destruction of the red cell, or even a loss of a red cell. So perhaps more investigation should be conducted in order to evaluate the cause of this anemia.
So the provisional diagnosis, obviously you're very anemic, and because of this age, which are most likely was a GI bleed. We wondered about whether it could be a peptic ulcer, of course a malignancy because of this age, and then we also thought about angiodysplasia, and angiodysplasia was considered because he has got aortic stenosis, and we'll talk a little bit about that later. Next, please. And Dr. Choi, maybe you can tell us what is angiodysplasia, why we are talking about it in this patient, and any other clinical exam that will help you with the diagnosis.
Sure. So like the name angiodysplasia, well, it's dysplastic blood vessel. I would say by definition, there will be some abnormal, maybe very friable looking blood vessels. I think commonly described in the, like what Dr. Khan is showing right now, submucosal layer of the GI tract, perhaps commonest in the colon. It can be friable, hence it may bleed. Highly prevalent in elderly, I guess, or kidney disease patients. But in our context, I think there's an interesting link to the aortic valve. When you have a very turbulent flow across the aortic valve, perhaps like aortic stenosis, it may link to some rare but maybe significant acquired, how should I call this, coagulopathy issues, which may lead to angiodysplastic condition in this patient, which is commonly seen in aortic valve disease.
One slide back. Okay. I think the last point is very important, especially for those of us in general practice. We see somebody who's looking very pale. One of the simplest things we can do is use our finger, do a per rectal examination to look for melena. We are thinking of a simple test to look for GI. And in this gentleman, there was no melena during per rectal examination. So one slide forward, and then another slide. Okay, then Dr. Choi says he wants to do some investigations. What would you like? Sorry.
Yeah, so I guess we should start from the basic test, like a hematological profile, platelet count, maybe iron panel, or even a full blood picture to look at the cause of anemia. ECG will be good to look for any possible arrhythmia or ischemic heart disease changes. A chest X-ray to look at the size of the heart and maybe perhaps also the other adjacent structures. More importantly, an echocardiogram to evaluate the aortic valve to see whether there's any progression of the aortic valve stenosis in this patient, and also ejection fraction for heart failure.
Thank you. It summarizes what Dr. Choi had said. Next, please. Okay, this is this gentleman's ECG, and 2 questions. Dr. Choi is going to interpret the ECG for us. Then we notice that he's anemic, and we expect the heart rate to go up, especially if it's acute bleed, and his history is very acute. It's a bit surprising that his heart rate is not fast. In fact, it is slow. So, Doctor is going to try to explain to us why this man has got bradycardia, even though he's not beta blockers.
Yeah, so it's a bit unusual for someone to come in with a relative bradycardia in an acute setting of anemia or bleed. Well, maybe his age has to do with this. When you have an elderly person, I guess the sinus nodal conduction or sinus nodal activity may not be that normal after all. And if you look properly, the PR interval seems to be very long. So you do know there's some kind of AV conduction delay in this patient, and there's no beta blocker or any calcium channel blocker on board. So you can either blame it onto his very, very marathonic stature, like maybe he's a very active, athletic person, high vagal tone, which is quite unusual at this age, or it could be just due to age factor itself. And that age factor will probably explain why he's relatively bradycardic, sinus bradycardic. And also on top of that, it's interesting to note that there's no significant ST changes that is remarkable, other than a little bit of a strain pattern, which could indicate some form of hypertrophy in him. Other than that, there's no Q waves to indicate significant infarcted areas, at least up to this point. Is there anything else, Dr. Kandan, that?
I think it's fine. I mean, that is towards the left, and that's probably his hypertension. Thanks, Dr. Next, please. So this is a gentleman's X-ray, so quite obvious he has got cardiomegaly. The lungs are relatively clear. I mean, you see some shadowing in the low zones, but I won't get too excited. But there's no obvious pulmonary congestion. So looking at this, I won't call this left ventricular failure. Next, please. This is the blood panel for Alan, who might not. Okay, maybe you want to comment, and Alan's going to talk more about this a bit later. You want to go, maybe go one slide forward and come back, Alan. Okay, I'll show the echo, then we'll go back so that Alan can tell us more. This is the echocardiogram, what we call the parasternal long axis view. Okay, let it run, Alan. So we can see, you see the structure that's squeezing away. That's the left ventricle, and it's obviously squeezing very well. So there's no LV failure. And then if Alan points a little bit at the bottom of the aorta, there's the aortic valve. Seems to be opening quite well. Then the next one, Alan, next panel. Good. And if you point towards the aortic valve, this is this band sign. So you see the valves, I mean, they don't open perfectly, but the degree of opening is quite satisfactory. The gradients we got was actually quite low. Its mean gradient was just about 15 millimeters per film, which is actually low. So you can quite confidently say in someone where the LV function is good, the gradient is so low that he has got no significant aortic stenosis. Then maybe we go back and Alan can talk to us about the blood. Yeah.
Okay, so this gentleman has moderately severe anemia, and that's quite a 2nd of March, and I think we are using an Egyptian medical record, so it starts from the right and then goes to the left.
Yeah.
So if you look at the right, it's an earlier one. So I think when he came in, isn't it, 6.5?
Yeah.
Then you notice the hemoglobin has gone up. I presume that's when he's been transfused. Yeah. Okay. In anybody who is anemic, the most important red cell parameter of all the PCV, MC, SJMC, and so on is the MCV, or the mean cell volume. because it will give us a clue whether or not what the cause of the anemia is. If its MCV is low, that's microcytic, then it could go for very long-standing iron deficiency anemia. If it's increased, then there's macrocytosis, then it could be due to things like beta folate deficiency, myelodysplasia, and so on. Here we have an MCV which is actually normal. So it doesn't exclude, it's not suggestive of iron deficiency, but you could have iron deficiency with normal MCV if patient is partially treated, a dimorphic blood picture has been transfused. But it could be due to blood loss if it is fairly acute without much time for iron deficiency to develop. The thing I want to comment about is the serum iron, which is low, at 4.5. Now, I think one will be tempted to diagnose iron deficiency on the basis of serum iron, but the caveat here is serum iron is not diagnostic of iron deficiency. Serum iron only reflects iron in your recent ingestion. It doesn't reflect your iron store. So actually, we would like to see more info, and let me share this for the GP. So when you see lab reports on the iron deficiency, how do you diagnose it? The two important tests to diagnose iron deficiency are actually the ferritin, which actually measures iron store, and something called the transferrin saturation. And this is something I just want to elaborate a little bit more. So what is the transferrin saturation? So we have serum iron in the iron panel, but why alone it's not enough is we want to see something called the TIBC, or total iron binding capacity. And the transferrin saturation, which is the more accurate measure of iron stores, is the ratio of iron divided by total iron binding capacity times 100. So it gives you a percentage. So if it is less than 20%, then we can say it is iron deficiency. So the iron level can be low, but the iron binding capacity could also be low. For example, in chronic illness, infection, and so on, leading to a normal transferrin saturation. So these patients with low iron may not have iron deficiency. Okay, so here it is. Low TSAT, less than 20%, that's the one which is diagnostic of iron deficiency. If it's normal, then that's normal amount of iron. And high TSAT, there may be actually too much iron. So this is actually more informative than just serum iron. So that's one caveat on the blood test. We will switch. Did I actually show my slide just now? No,
I did not see the slide.
So sorry. Let me go through that. Yeah. Sorry. So too many screens, so I got confused. So TSAT here is the serum iron divided by TIBC times 100. Okay, so that's the one we want to see, not just the serum iron. We want to see the TIBC, and then the ratio times 100 gives you the transferrin saturation. And low TSAT is the one which is diagnostic of iron deficiency, not just serum iron by itself. I know some labs just like to give you serum iron, but ask for the TIBC and then the transferrin saturation calculation to look for iron deficiency.
How about serum ferritin equivalent? You mentioned that
ferritin is a simple one-step test. So low ferritin, usually less than 20 or so, would be diagnostic of iron deficiency. The caveat about ferritin is also an acute phase reactant. So in conditions like infection, inflammation, arthritis, and so on, the ferritin can be elevated. So it may look normal or even high, but these patients may be iron deficient. So it can be falsely normal or even high in the inflammatory state. So that's one caveat, that the ferritin may be misleading in some instances. But if you have a low ferritin, that's diagnostic of iron deficiency. So both these tests have their CAT you need to be aware of. Okay, let me see if I can get the screen sharing right. Okay, we will move on.
We'll go to the next slide. Next.
So,
I think you have already explained this. Next, please. Okay, so he underwent a gastroscopic examination. This just showed enteral gastritis. The rest of the gastroscopy was normal. The colonoscope was also normal. So the gastroenterologist said, okay, we will treat him because he's got severe anemia and he's got all the other comorbidities, and then we'll watch him. If he was to bleed again, then they will have to do a capsule to look at the small intestine. So he had blood transfusion, he had iron transfusion. Of course, because there was this bleeding thing that we were worried about, we withheld his pelvics for 2 weeks, and then we restarted them. For those family physicians listening in, if one of your patients has recently received a stent, please do not stop the antiplatelet agents without talking to the cardiologist in charge, because this could lead to acute stent thrombosis and sometimes even death. But if the stents have been in for about a year and necessity arises for us to stop antiplatelets, we can do that. We also told him that he probably requires to take a PPI lifelong. And at the time of this discussion, this happened for 6 months ago, and he remains asymptomatic. Next slide, please. And next. Okay, just a few points because this man presented with blood loss and he's got aortic stenosis, and as Dr. Choi mentioned, aortic stenosis is associated with increased friable cells in the intestinal system, and as we see most commonly in the small intestines. So about 3% of between 1 to 3% of aortic stenosis patients have significant GI bleeding. Next, please. And there's an increased incidence of angiodysplasia in patients with aortic valve disease, as Dr. pointed out. Next, please. It was very interesting for me to find that TAVI, which is trans catheter aortic valve replacement, that is increasingly coming to vogue now, without going on to aortic valve open heart surgery for aortic valve replacement, as well as the older studies where aortic stenosis is corrected with replacement of aortic valve, will correct this condition. And thinking is, as Choi mentioned, that because you've got a stenotic valve, there's turbulence to the blood flow. This causes disruption in some of the clotting factors and leads to this. And once you correct the stenosis, the GI bleeding actually goes away. Next, please. And in patients who present the GI bleed at older age, especially, the associated prevalence of aortic stenosis is about 30%. I had more slides to show here, but in the interest of time, I'm going to swing right over and go through now. I think we will go past this. It's just a Japanese study to show in that series where they had patients with aortic stenosis and anemia. They discovered quite a few of them had angiodysplasia. They went on to do very successfully, and in many of these patients we follow up, the angiodysplastic lesions just disappeared. Next. So we go on to the second case. This is a 63-year-old lady from my hometown. 10 months before seeing me, she had developed a cough. And this was treated by a family physician in Muar as upper respiratory tract infection. 1 week later, she presented with blood fluctuations from exertion. And she had no symptoms at rest, no chest pain. A chest x-ray had been done, and the x-ray was thought to be normal. And she was given antibiotics for 2 weeks, and the diagnosis was pneumonia. There was no fever, but the cough continued. The sputum was clear. Next. In August of 2023, she developed progressive dyspnea on effort. There were no symptoms at rest. In November of the same year, she noted that she was having bilateral leg swelling, which progressively got worse. Then she went to Malacca. A lot of patients in Moa do go to Malacca because services in the town is not enough. And for the first time, heart failure was diagnosed. Coronary angiogram was done, and a 40% stenosis of the proximal left anterior descending artery was found. And they decided to stent this, and most of us would not have done this. And certainly, we don't treat a 40% lesion. It will bring the patient no benefit at all. Well, not surprisingly, the patient found that leg swelling got worse. Next, please. She had no known medical illnesses in the past. She never smoked. She worked hard as a commissioner of oaths in the town. Her appetite was normal. She does not consume alcohol, and there were no symptoms to suggest thyroid disease. Retrospectively, there's no history of bone pain. This becomes relevant as we delve into a case more. The family history: a younger brother needed bypass surgery 10 years earlier, which was done in our center in Sumatra. Clinical examination revealed that she was cachectic, but she looked very comfortable. Her blood pressure was just 70 systolic, and I was shocked because she just walked into the room looking comfortable. Pulse rate was 84 per minute regular. Next, please. Her jugular venous pressure was elevated all the way up to the angle of the jaw. And she had bilateral, and I must say that it was pulsatile. There was bilateral lower limb pitching edema up to her knees. Next, please. She was not pale. The heart essentially clinically examination normal. The lungs, there was bilateral basal crepitation. In the abdomen, there was firm hepatomegaly. But 8 cm, the liver was not tender and was not pulsatile. Next, please. So, Dr. Choi, based on the clinical examination, what differentials would be considered?
Yeah, so based on the low BP and clinical signs that probably suggests more of a cardiovascular cause with the elevated JBP, edema, and the pulsatile signs. I'm thinking more of a cardiac-related cause. For example, anything that can lead to cardiomyopathy. She had history of 40% stenosis. Maybe you would have progressed despite the stenting. So ischemic heart disease is one of the possibilities. She had a bit of fever and cough as well, maybe myocarditis related to the viral infection, or nothing related to the heart muscles like the pericardium, maybe a TB pericarditis with constrictive pericarditis. These are all cardiac related differentials I can think of for this patient.
So this kind of summarizes what Dr. Choi has said. I mean, this patient has got virtually no premorbid. She's not diabetic, not hypertensive, because she has a family history of coronary artery disease. Angiogram done not too long ago did not show any significant heart disease at all. So a few other things come to mind in someone who's been healthy before. Rarer things like whether it's a myocarditis related infection and everything else that Dr. Choi has mentioned. Because the clinical signs suggest some sort of constrictive thing happening in our heart. Okay, go on, please. So this is the patient's ECG. I apologize; it looks rather very light, but we can make it out. And Dr. Choi can interpret the ECG for us. Sure. And one question we would like to ask is, this patient does not have any significant coronary artery disease, but she has Q waves or very poor R wave progression from B1 to B4. What are things to think of?
Sure. One look, the ECG looks stable, regular. That's my first impression. But I'm sure most of us will agree that the complexes seem to be rather small for someone who has no real cardiac issues before this. So I would say it's like a semi low voltage kind of impression, and that's the first thing. I can't really make out of the P, but I think the P waves are there, so it's sinus rhythm. There's no significant AV block in this patient. But if you measure the QRS width for most of the complexes, I think most of us will agree that it's not really that narrow. So I would say some degree of intraventricular conduction delay is also there. So something is going on in the conduction system, which is a bit slower than expected. Now, to explain the V1 to V4 Q waves, I mean, without knowing the patient's clinical condition, of course, top of the list is always the LED infarction. Anything around the anterior part of the wall which is infarcted, with or without a real vascular stenosis. That's the first possibility. Of course, pseudo infarction is also something that we can think about. For example, patients with very, very thick heart muscles. So if a patient comes in with a very thick heart muscle, for example, a hokum or other type of non-muscular type of thickening, like infiltrative heart disease, sometimes it may give rise to all these pseudo infarcted waves as well. So I think it'd be interesting to look at the images after this to explain further.
So I think I covered most of it. The other thing, of course, is that the heart rate is rather slow for someone who has got quite heart failure. And usually we see this when you're throwing beta blockers and all that to treat heart failure, but she was not on it. So probably the conduction thing is causing trouble. Next, please. So this chest X-ray, and obviously the heart looks big. You can see a big right pleural effusion. If you look at the pulmonary veins, they're all congested. I mean, she's got congestive heart failure, there's no question about it. Next. This is the echocardiogram. It's a very interesting echocardiogram. Now, what we see on top here, can let it run, Alan. First, you see the contraction of the ventricle. The ventricle is on the left side, right? So the contraction of the ventricle is rather sluggish. You also see that the heart muscle is very thick and also very bright. And normally we see this in someone with hypertensive heart, where you see that the heart muscle is very thick. But that bright pattern, for those of us who look at echocardiograms, the bright pattern always tells us that this is, always suggests to us that there's some sort of infiltrate process that's making the heart muscle very bright. And the left atrium, that's the one just behind the mitral valve, which is big, that indicates to us that the pressure inside the left ventricle must be high, so it's difficult for the left atrium to empty blood into the ventricle, so it begins to enlarge. And you see a big space behind the heart. Maybe I didn't show. That's right. That's a big pleural effusion. Yeah. So Choi pointed out that when you look at the ECG, the complexes are rather small. So if this is hypertrophic muscle, as you see in hypertrophic cardiomyopathy, or if you see in hypertensive heart disease, you will see very tall voltages because the muscle is producing a lot of electrical activity. If the complexes are rather small, as Choi pointed out, and the muscle looks so thick, then you have to think about infiltrative heart disease. And one of the things that all of us will jump on is whether this amyloid heart. So there's the next panel shows the 4-chamber view, again showing reduced contractility of the heart. The two chambers at the bottom, that the atria, that's the right atrium, the arrow is showing there's a left atrium, and both of these are dilated. And we also can see a small pericardial effusion. There's a small space surrounding the heart. So when you look at this, you say this infiltrative heart, all of us will be thinking whether this is amyloid heart, putting the ECG and the echo. Next slide. Okay. So she was admitted in intensive care unit. Surprisingly, in spite of the low blood pressure, she remained comfortable. Her appetite was good. When I'm going to see her, she'd be having her lunch and her dinner. But BP was just 70. The urine output was very poor. The first day she came to us, she had just put out a small amount of urine. The next day, the amount of urine was actually very little. And it was very difficult because the BP is low. You can't give her diuretics. Next slide, please. Nothing much to report in the blood counts. The renal function is mildly impaired. Electrolytes, the sodium is a little low. Interestingly, the albumin is quite good at 38. A lot of these patients with heart failure, you find the albumin will drop very fast. And the liver enzymes are also okay. Next, please. So because of our hypotension, it wasn't possible to start the usual anti-failure medications. All we could do was give her some inotropes. Next, please. And so, as I've mentioned, infiltrative heart disease was strongly considered based on the echo and ECG findings. So we made a decision to transfer her to the Institute Jantung for further investigation. I thought that she required a cardiac biopsy and appropriate therapy. Next slide. So she continued to be, I kept in touch with the doctors at IJN. She continued to be hemodynamically unstable, and they couldn't investigate her. She was unfit for MRI, she was unfit for cardiac or bone marrow biopsy. Next week. And they did some blood tests. And Alan, could you run through it and tell us what you think?
Okay, so the important finding here is there is a so-called Benz-Jones protein identified. The Benz-Jones protein is the old test for myeloma, but the new test, the preferred one, is actually detection of light chain. Actually, because light chains can give a positive Benz-Jones, but also Benz-Jones is a heat test, can also be false positive by detecting other types of protein. So if you do an electrophoresis in the urine, that is more specific. In fact, you're done and it shows a pain-free kappa light chain detected in the urine. So there was, is there a serum electrophoresis?
I think it goes through the next three slides are all
Okay. So here you have kappa and lambda free light chain assay, and most important is the kappa lambda free light chain ratio. Maybe I better do some revision of what is kappa and lambda.
Yes.
So if you guys remember from medical school days, the antibody has a heavy chain. So there's a big heavy chain which gives the name of the antibody. So immunoglobulin A, G, D, E, and so on. Okay, so that's the heavy chain component. Then the binding component, there's light chain. And there are two types of light chain, either kappa or lambda. So now, plasma cell disorders are clonal. So you only have one type of heavy chain and one type of light chain. So you see a report for plasma cell disorder, protein electrophoresis, you will see one type. So it's like IgG kappa only detected, or IgG lambda, for instance. Here we don't know what heavy chain. I noticed the protein was not very high. Only the globulin was actually normal. So it seems to be more a light chain disorder here. So which is that another slide? Yeah. Okay, so they did electrophoresis, and what did they detect? There's only faint kappa light chain band on immunofixation. So they didn't detect a significant paraprotein. And the kappa light chain is actually not very high, but the ratio is abnormal. So the issue is, what is it? So maybe, I'll try to share my slides this time. Right. Tab and share the slide. Okay. So the question is this amyloid of the heart? And if it is amyloid of the heart, is it myeloma, or is it AL amyloidosis? I think these are the two possibilities which come to mind. I just want to do some revision on this. So both are plasma cell disorders. They are all related. Okay, it's more like a spectrum. To say if somebody has myeloma, these are the current criteria. We need to show clonal plasma cell involvement in the marrow or a biopsy specimen. And we need to demonstrate, all you need to remember is ROTI. ROTI means related organ or tissue impairment. And what are these related organ or tissue impairment? It's determined by the criteria. And it's all you have to remember, other than ROTI, we need to remember CRAB. Okay, so CRAB is hypercalcium. Yeah, roti crab sounds like some seafood dish. So you eat the mantau bread and crab swimming in some delicious sauce. So that's how you remember the diagnostic criteria for myeloma. So the CRAB feature are hypercalcemia, renal impairment, anemia, and bone lesions. And this should be related to myeloma. That means we are not saying renal impairment means diagnosis, because if you renal impairment not due to anything else, like diabetic nephropathy, or not anemia not due to anything else, but attributable to the myeloma. Okay, note that the amyloid of the heart is not ROTI as in the diagnostic criteria. In the more recent years, we don't just rely on the CRAB features, but there are significant biomarkers which actually have been enrolled in the diagnostic criteria. If we have very high levels of plasma cells, more than 60%, or if there's a very high free light chain ratio more than 100, that is alone diagnostic of myeloma. Any of the CRAB features and any of these biomarkers is enough to diagnose multiple myeloma. So this lady had a free light chain ratio just over 100. So in the absence of anything else, she indeed has one diagnostic criteria for multiple myeloma. So this is most likely myeloma, and this is most likely amyloid of the heart. But I say it is most likely. I'll just go through a little bit more. So I just mentioned two types, kappa, lambda, and so on. Okay. Now, okay, we are back. Sorry. Let me get the screen. So this is where we were. Let me share my. Okay. So amyloid is we need a biopsy. So this lady, I gather she didn't quite reach. Anyway, cardiac biopsy is quite. They has this risk, isn't it?
Yes.
You can perforate the cardiac muscle, and not many people in Malaysia can do a cardiac biopsy. If anything, IJN should be able to do it.
Because they are doing heart transplant, so it's part of the protocol,
But the other sites you can look for amyloid, which include biopsy of abdominal fat, kidney or rectal biopsy. So sometimes we result on it, and bone marrow as well. So we have a plasma cell disorder producing a lot of light chains and causing amyloidosis, but there's no criteria fulfilling myeloma. So actually, we should not have a free light chain ratio so high, like 100, so it's less, and the number of plasma cells in the marrow and all that do not fulfill myeloma criteria. That's how we diagnose light chain amyloidosis. But in practice, if you diagnose whichever, the treatment is the same. We employ more or less the same drug now to treat light chain amyloidosis as well as multiple myeloma. But the prognosis to me in light chain amyloid involving a heart is a bit more guarded. Yeah, it's a bit tougher to treat. And in actual fact, the percentage of patients with light chain amyloidosis, AL amyloidosis, developing myeloma the other way around is much less, simply because they may not live Sorry, we lost the connection again. Our internet is pretty bad. So if my connection is lost, we lose the audio because the audio is linked to my account. Apologies for that. So where were we? I hope you all got the light chain amyloid part. Anyway, if there are any questions, you can ask me if we go on and on.
We had a discussion before the Wi-Fi caused trouble, where Alan shared a case of someone with multiple myeloma and amyloid involvement of the heart and liver, and kidney. And Alan said that they treated the patient quite successfully, and there was some resolution of the amyloid in the heart and the kidney. So that's very encouraging.
There are other types of amyloidosis. Just to remind from your medical school, there's AA amyloidosis is secondary to chronic infection and inflammation, and the rare one called TTR amyloidosis due to mutation in the TTR gene. Okay, but anyway, this is just academia, so we maybe will move on to the presentation here. Okay.
Right. So this patient unfortunately continued to be unwell and died 2 weeks after admission to IGN. The final diagnosis is multiple myeloma with cardiac amyloidosis. Next slide. We'll try to rush through this because time is running out. So I was digging the literature and I found this case history from India. And it's a lady who presented quite similar, same age as our patient. And basically, she presented with heart failure. They went on to diagnose her as cardiac amyloid and multiple myeloma was picked up. And as Alan said, that they did not resort to a heart biopsy. They did a cardiac MRI, which was consistent with amyloid. They did abdominal fat biopsy, renal biopsy, and both of that picked up amyloidosis. And bone marrow confirmed multiple myeloma. Next one, quickly, Alan. So, yeah, I'm sure Alan will agree. These are the drugs that were given. And this patient had a good outcome at the time that they wrote the report. The patient's myeloma had been controlled, the heart failure was controlled, and they were working towards getting a bone marrow transplant for her. So maybe in the interest of time, we'll quickly go on because Joy has got a case.
No audio at all. Somebody is saying. Oh, let me check. Testing 1, 2, 3. Yeah,
you say okay.
Yeah, it's okay.
You say it's okay.
I think just now when I was disconnected because our conference microphone is connected to me, so the audio when my video is off, the audio is off, but it should be okay now. So that's triplet therapy for myeloma, but nowadays we have quadruplet. Using monoclonal antibody daratumumab plus bortezomib based triplet, so it's more aggressive. Yeah. Okay, let's move. We've got 10 minutes. Is that all? Yeah. Okay. Marrow transplant, yes. If the patient is young enough and can get the transplant, that would improve the survival. 50% of patients with amyloidosis have cardiac involvement, and cardiomyopathy is part of presenting manifestation, and amyloidosis is rare. One of the things I learned at some of our hematology meetings is those with milder forms that haven't reached myeloma. There's an earlier stage called smoldering myeloma, and even earlier stage called MGUS, or monoclonal gammopathy of unknown significance. So usually people will say, oh, this paraprotein very low level, we see you every now and then, monitor you and all that. But actually, we actually have to watch the expert advice. We actually do the pro-BNP regularly and make sure we are not missing out early cardiac amyloid. So yeah, so that's something we now have to keep in mind. This case reminds me, we see MGUS doesn't mean all is well. We need to watch out for
MGUS is what again?
Monoclonal gammopathy of unknown things. So there's no criteria for myeloma. The paraprotein level is very low. Otherwise, they are very only a small percentage over 10, 15 years develop myeloma later. But they could develop light chain deposition and amyloid along the way. So we have to watch out for that. Okay. First case, which is
Your sending first. Yeah.
Okay, I hope my connection doesn't go off. Am I still all right? Okay.
Yeah, all right.
Yeah. Right, this is a young final case which came to mind because it happened right after our last grand rounds. After our last grand rounds, we had the emergency referral for a young man with acute restlessness. And am I presenting right? Yeah, okay. This is a 28-year-old man with 2 weeks of restlessness, so very recent onset. He was unable to lie flat and he had no previous illness. He was very large, 128 kilograms. He was orthopnic, dyspneic, and on nasal oxygen. You notice he had dilated veins in the chest, right pleural effusion. He was also very tachycardic. And we had the benefit of knowing that he had a pericardial effusion from an echocardiogram done from the referring hospital. So, cardiology colleagues, so we will move over to your slide. Sorry.
All right, so just a recap again, what Dr. Allen has mentioned. So the thing I would like to emphasize is this is a 130 kilo man. So it's a big size, very, very big size man. Tachycardic, BP is normal. So when I saw him, I got referred, he was sitting up almost like a 90 degrees because he couldn't even lie down, not to the slightest degree at all. So every time he sits up, he feels a bit better. Oxygen is about 98 on high flow mask. But the moment he goes down, then the saturation will just drop. Lungs basically just nothing much other than reduced air entry both sides, and he has a very dynamic neck plethora. What I mentioned, the moment you lie down, you look a bit more reddish and bluish, and this is how it feels a bit better. So just for the sake of a discussion, when you see someone with this kind of a dynamic plethora, is there anything that you would like to highlight?
I think Alan said that when the initial clinical examination also showed a lot of dilated veins in the chest. So that always will get us very excited. And then you found a jugular vein was elevated. I asked you whether it was pulsatile. You said it was all the way up, so you can't even decide whether it's pulsatile or not. And sometimes what we do, if they're well enough, we ask them to stand, then you might be able to see the top of the JVP, so to speak. So one of the things that you think about when you see all these dilated veins in the chest is whether this is superior vena cava syndrome, where the superior vena cava is obstructed. Usually it's due to a tumor. And then he's a very young fellow, so he's 28. I mean, an older person think of carcinoma of the lung first. Young person should think, well, it could be a lymphoma is one thing, and certainly thymoma is the other thing to think about. So if you leave that aside, this is a very fat fellow. So he's big with chin. So that by itself can cause heart failure. I mean, it's very hypoxic, very hypercardic. So he could have congestive heart failure just from being a big kid. And of course, other causes of heart failure in a young person, if they have myocarditis, cardiomyopathy, are some of those things you want to think about.
I totally agree. And in fact, those days we talk about Templeton sign, trying to lift up the arms. I didn't even dare to attempt because it was so widely ill and in distress. So anyway, I think we can skip this slide. It's a CT scan that was reported by the previous radiologist, stating that at that point they thought it was a thymoma with SVC obstruction, most likely to be a malignant tumor in terms of the infiltration, with pleural effusion and also pericardial effusion. So ECG, nothing much, sudden tachycardia, and this is the X-ray. Dr. Allen, I think anything to add on?
Yeah, I mean, you can see the superior median sign is very widened. Okay, that's not normal. Yeah,
the shadow over here, right?
It's also very large, right? Pleural effusion. And we see a big mediastinal tumor like that, we worry about not just thymoma, whether it could be a lymphoma or sometimes even germ cell tumor or even other cancers. But these will be the three components.
At this age, I mean, based on your experience at this age and gender, which one would be more likely?
Well, there is a referral bias, so we see lymphoma. Occasionally, we do get thymoma and germ cell tumor.
I see. Yeah.
Okay. One more comment about the X-ray.
Sure. Let me just go back. Yeah.
I think X-rays are important for us in general practice. Yeah. There's this thing called a central sign. So if you look at especially the left border of the heart, it looks very sharp. If you look at the lungs, they look relatively clear. So when you see such a sharp demarcation one of the things you think about is whether the pericardial space will activate. So it's a nice demarcation between air and water. So it is a very soft sign. We don't have echo and all that. You look at it, and then the heart looks big. One of the things you have to think about, could there be a pericardial effusion?
Yeah, good point. So indeed, so I'm showing you the echo now. Maybe Dr. Kannan, you want to continue with your comment on this?
For all of you would have seen the earlier echoes I showed. This is an echo where the heart is happily rocking away. Is it juggling all over the place? But because surrounding it there is water, so it is essentially swimming. Okay, that's what this can show. There's a collection of water around the heart.
Correct. Okay. And also just to mention that it appears a bit tachycardic as well. Yeah. So so same like what Dr. Kannan mentioned, there's fluid around. Maybe I'm not sure how many can appreciate this, but this is the right ventricle, and you can see the pericardial effusion over here. And you can see occasionally the right ventricle seems to be struggling to expand. Yeah, so the term that cardio would like to use is actually RV collapse. So when you see a sign of RV collapse, means that the right ventricle is getting a lot of struggle trying to expand and to fill. So that may not be a good sign. So and on this view, apical four chamber, anything else to add?
You see the pericardial effusion. The other thing that you see right at the bottom, if Troy can point out, you can see what is this is right atrial collapse, which is another sign, just like that, right ventricular collapse, indicating this effusion is significant. It's not a mild effusion.
Yeah, correct. So this area right, Dr. Kannan? Yeah, okay. So there's a right atrial collapse seen on this echo, and
sometimes you see a very interesting ECG. What's that?
Alternates.
Yeah. So you see one QRS complex big, another QRS complex small. So that's called electrical alternate, which is a good sign, ECG sign of picking up, because the old days before echo, that's all we had.
Those days, yeah, because of the swinging of the motion of the heart. So this is a fixed M mode. Just to sometimes we can do that. We try to demonstrate where the buckling of the right atrium is. So if I'm not sure how many will agree, but you can see that the movement of the right atrium, there's a sudden change. So it means there's a sudden change. There's a point where the right atrium fails to expand. So this could be a very easy way to pick up a right atrial collapse. And in fact, Dr. Kannan, now that you mentioned, I see a bit of a change between this QRS and this QRS, maybe a bit of alternating complexes as well. So all do point towards a significant degree of effusion, and this is what we call the mitral inflow variation, right, Dr. Kannan? Yeah. So when you see that, it tells us that this effusion is significant.
Inspiration. You want to describe that?
Yeah. So during inspiration, usually there's a bit of a increase, reduced venous return initially. Then I think the right ventricular interdependency causing more of a variation of the inflow to across the mitral valve. So if you plot the respiratory meter here, you can see that when the patient breathes in and out, the inflow across the mitral valve seems to be, I think 25%, right? Yeah. Increase.
During inspiration, the amplitude looks smaller. During expiration, the amplitude looks higher. So it's another sign for significant effusion causing tamponade.
Right, and maybe in terms of clinical findings, one if we were to check the pulse, the pulse volume may also be respiratory variable. So simple words, this is a pericardial effusion with tamponadic signs. So with hemodynamic instability, the decision was actually to do a pericardial tapping. Now, it was quite challenging because normally, when you have a patient with pericardial tamponade, you try to lie them down and you tap the effusion. But he is a very big sized man, and every time we tried to lay him down, he became hypoxemic. So I got Dr. Suresh, our anesthetist, and thanks to him, we put him on the CPAP, and that's the only way for us to put him down almost supine. For us about maybe 15 to 20 minutes, and we have to do the apical approach because it's faster and it's shorter. After confirming the pericardial space, we aspirated manually and left the drain, and he improved clinically as well. Dr. Kannan, based on your years of cardiologists in this center, and pericardial tapping under emergency. Anything else you'd like to comment?
Basically, you have got two approaches as you mentioned, the subxiphoid, and this man is very challenging because of the size. The unit is just above the epigastrium. The other one, of course, the apex. Apex is always faster. We use ultrasound, locate where the space is widest, and then we use that to guide the needle in. And of course, we use fluoroscopy. That also helps because we put in a wire, you can see it around the heart. Yeah.
Yep. So just one slide to share. Not sure how many listeners are doing cardiology. So I guess we all learn the hard way when you tap the pericardial space. The golden question is always, are you in the space or are you in the right ventricle instead? Because if you're in the right ventricle, when you put the drain in, that's probably the end of it. You have to send the patient to the OT in order to salvage. So one good trick that I learned is that whenever you're in, before you even put in any dilator, if you have the fluoroscopic facility, put the wire in as long as possible. Just push the whole wire. If the wire coils from one end to the other end and goes all the way back, it cannot be in the heart chambers. It may be right ventricle or left ventricle. Because it's not how the wire coils. It can only be in the pericardial space. So you can push wire all around the heart, you are in the right place. So just to share, in case some of us that are doing cardiology. And anyway, so this is the follow-up echo. And as you can see, there's not much fluid left. The drain has been removed, and he was treated accordingly. Maybe back to you, Alan.
Okay. Thanks, Joy. So let me try to share back my slide. Okay. I just remember many moons ago when I was training under a physician in general medicine. When you do a pericardial tap, one of the ways to know where you are is attach the ECG to the needle. So you see the electrical voltage, you know where you are. And this was the great Dr. SJMC who followed that. I think you remember doing one tap. I wouldn't dare do another one.
Marrow taps.
Now only marrow tap, no pericardial. So, yeah. Okay. Anyway, let's see what happened to this patient. So he was very fortunate that it was after a cardiology grand round, very easy to get hold of Dr. Choi because he was still around, and the cardiothoracic surgeon was able to insert a fluid drain to stabilize this patient who was actually very acutely fractured. So by draining the heart and the lung, it was much better. So he underwent a biopsy of the mediastinal mass. After the biopsy, we started him on steroids. The differential is still highly some form of lymphoma, and thymoma is still possible. You can do a beta HCG and alpha fetoprotein to exclude the germ cell tumor. In fact, that was done and was not elevated. So it's between lymphoma and thymoma. PET scan staging was done, and I just show you the PET images. And this one, where a PET scan will tell us where the metabolic activity. You can see it's really all in the mediastinum, right on top of the heart. So there's a huge tumor, very, very bright. The brain is also a normal place where there's a FDG uptake in the PET scan, because it's basically a scan which shows you glucose metabolism. So unless your brain dead, the brain will be a normal place, and also the heart is where there's a lot of glucose metabolism. So the heart is pretty normal. Of course, this patient also has pericardial, but you can often see heart muscle pick up PET normally. So final diagnosis, as it turns out, is this is actually a diffuse large B-cell lymphoma. Okay, so the markers here, the CD20, so on, are all consistent with B-cell lymphoma. So now this is a very rare type of diffuse large B-cell lymphoma. It is limited only in the mediastinum. So this is called a primary mediastinal B-cell lymphoma that forms in the mediastinum, which is the space between the lungs. It typically occurs in young adults, female a bit more than male. And actually the prognosis is actually quite good nowadays. Once you stabilize them, you have to recognize it, the superior vena cava syndrome like he had, the dyspnea, stabilize it, and treatment with monoclonal antibody, the rituximab here, and dose-adjusted EPOC, which is just the acronym for the type of chemotherapy agents used, are very highly effective in PBML. And the event-free survival, or lymphoma-free survival, is like 90% with long-term follow-up as described in some series. In fact, our own experience here is very good with dose-adjusted EPOC, and almost everyone is still alive in some years down the line. So that's the last slide that I have, and I think time is we just exceeded, but we allow the exceeded time because of the sorry about the interruption in our internet, but that's the vagary of it. Let's see whether there are any questions on Slido or YouTube. Okay. If you have any questions, please feel free to ask us in YouTube. Slido, let me get there now. Yep. Okay. We will start with the oldest first. Okay. Top question, does the old man with first degree have heart block and deal with prolonged PR interval?
Yes.
Yeah, correct.
Sorry, I mentioned that.
Okay. Second question is directed to me. What is TSAT? I'm sorry I lost the slide at that time, but TSAT means just a short form for transferrin saturation, which is calculated from the ratio of the iron divided by the total iron binding capacity, or TIBC. So to really diagnose iron deficiency, you need iron divided by TIBC times 100, which gives you a percentage, which is the transferrin saturation. If that is less than 20%, that's diagnostic of iron deficiency. So serum iron alone is not enough. We need the TIBC, and then you calculate the transferrin saturation. Usually the lab will do it for you if you order a complete iron panel. So that is as good as the ferritin. But sometimes we do that if we worry that the ferritin won't be very accurate. Say somebody who's unwell with some fever, chronic illness, we do that. Ferritin may be falsely low or even high. So then you order an iron panel instead. Next question, between TAVI and surgical replacement, which will reverse angiodysplasia more?
I think there are no studies to compare from what I know, but all the reports that we're getting is that both modalities of correcting the aortic valve will reverse angiodysplasia.
What is the mechanism for the association with angiodysplasia, and why does it reverse?
The only thing that I couldn't quite understand that. I mean, what the correction of the aortic valve is, you no longer destroy the clotting factor, your one milligram. But how that causes the angiodysplasia and how it causes it, that I can't answer.
I think
but one is clotting, one is vessel abnormality, isn't it?
What you're describing is acquired von Willebrand syndrome associated with aortic valve stenosis and sometimes mechanical heart valve. That's very rare also. I mean, von Willebrand disease is usually we see the inherited type. So lack of the von Willebrand factor is important to bind with platelet as well as bind with factor 8, stabilizer factor 8. So it's important. Also, it's important if you have von Willebrand factor deficiency or dysfunction, then you get platelet dysfunction as well as factor 8 clotting problem. So usually you see inherited. That's common is the acquired type in adulthood, and the ones I've seen are usually autoimmune, but they have been also described in cardiac causes due to shearing of the von Willebrand protein in the last few years. So, but I don't know how it ties with angiodysplasia.
I tried to understand, but I couldn't find anything in the literature that explains it. But there are several studies to show that the Japanese study where they took 50 patients, and there the incidence of angiodysplasia was actually very high. They got about 48 out of 50, which I think is a very selected population, aortic stenosis and anemia. So I think there the issue is high. But a big resolution, I think more than 60% resolution after they did the TAVI. So the clotting thing improves, but how the vessels resolve and why they resolve, I don't know.
What I do see, because I had a few patients with angiodysplasia, sometimes we can spontaneously resolve by themselves also. So maybe maybe you need more cases.
Yeah.
Can you comment on the usefulness of coronary artery stenting done in the second case?
As I mentioned, should not be done. Should not. I cannot emphasize even more. Should not be done. No benefit at all.
Why was steroid started on the third patient? The patient had superior vena cava syndrome, and the tumor is huge and it's compressing on the vessel. So while you get the biopsy done first, which is what we did very quickly, all in the space of 1-2 days. And steroids actually, while waiting for the actual histological diagnosis, will help at least relieve the compression, relieve the swelling. So it's actually more for symptomatic and urgent treatment before you institute the specific treatment, which is chemoimmunotherapy in this case. The last question is a number. I don't know if it's a code, but no, that's a, so let's see if there's anything on our YouTube. No. Okay. So I think we've overshot time. Yeah, I think it's a great discussion. I think a lot of very interesting cases, Kanan. So we are at the point where the drilling has started.
Yes,
So there's renovation in the hospital, so it's disrupting our Wi-Fi, and there's creating a lot of noise in our background. So sorry, but here's the part where you're all waiting for. This is the attendance link for you. Please note that the QR code does not scan with the MMA app. You just scan this QR code, which will take you to a attendance form. Okay, and you fill up the attendance form, and the SJMC team will upload the points for you within about 7 working days. All right. Later tomorrow, I will put up another way. If you're not watching this live, we will make this webinar also still watchable and claimable for CPT points. If you look at the pinned comment, I will do this only tomorrow because we give time for people to fill up the form and submit the attendance, which is the preferred way. So we will give you a way to claim your points, even though you have not watched this live. So not to worry, okay? I just want to, while waiting for people to scan, I just want to show a reminder that you can see all our past SJMC Grand Rounds if you visit our playlist. So the shortcut link for the SJMC Grand Rounds playlist is docs.my/SJMCGR Grand Round. So it's quite easy to remember. Okay. There is another playlist you might be interested in. Dr. Jamala had requested us to upload the entire cardiology symposium, the SJMC cardiology symposium, which was held in January this year. You can't claim CPD point, I'm afraid, but all the teaching videos have been uploaded, and starts with Kanan giving his lecture. So you can go to see all the 5 videos at docs.my/SJMC and CS for Cardiology Symposium 2024. So that's free to watch, okay, for wonderful education, especially for GPs. I think they are great teaching sessions. So just a reminder again, our grand rounds are always in this playlist, so you can view all our past ones. Okay, and for this cycle, we will, and also for selected months in the previous cycle, we'll try to reactivate them so that you can still claim points. So you feel free to watch, and you can still claim points for last year's cycle as well as this year's cycle. But last year's one will need a bit of reactivation, so be patient. All right. Any other comments? Let's see. Okay. If not, we will call it a day. I'd like to thank Dr. Kanan and Dr. Choi and this for this where blood and heart come together. Okay.
Have a great long weekend, everyone.
Yeah, happy holidays.
Happy holidays.
Take care. If you're traveling, drive safely. All right. And see you in the next one. There will be a medical legal webinar at the end of July. Okay, that will also be the first one for dogs. And next month, let me give you a little what do you call it? A sneak clue. It is going to be something to do with neuro and the heart. Okay. All right. So see you next month as well for our next grand round. Bye bye, everyone.